transferable.
So this is cutting edge information, or just came out last January, right?
About 8 weeks ago.
Yeah. So the capacity, the ability of HDL, the good cholesterol, to be protective is a key issue, not so much the number, the absolute number of the HDL. Very important. The second question, you talked about nitric oxide. You know, I learned a lot from you about this. You are Dr. Nitric Oxide to me. Yeah, you are. No, you mentioned to me that people received the Nobel Prize for identifying nitric oxide and its function. How far has the analytical laboratory science come to develop a test to measure the nitric oxide? Can that be done?
You know, interestingly enough, it is very close to being there by what we call the brachial artery tourniquet test, which is one. Another is a peripheral arterial tonometry, both of which are capable of really quite easily measuring nitric oxide. But still, from a practical standpoint, the way for any one individual patient to know that they've got optimal nitric oxide, if they are totally eating plant-based nutrition and they are no longer injuring their endothelial cell, which makes the nitric oxide. We have data on reperfusion models. You've heard me talk about the PET rubidium dipridamole test, which is nothing more than a fancy way of seeing if the red blood cell can get back into the heart muscle. How promptly can that happen after somebody changes their diet? Because that's a reflection of their ability to make nitric oxide. 3 weeks, we've seen that.
So in 3 weeks, you would actually have better oxygenation of the heart muscle.
You can restore the endothelial capacity.
Which also means you would have probably less angina pain then, right?
Oh, totally.
Yeah. So it's not only that the blood gets thinner, the viscosity becomes less, but it's also you have now the addition of higher nitric oxide levels.
And your HDL is now coming around and helping you again. And because it not only does it withdraw bad cholesterol from the artery back to the liver, it also serves as an anti-inflammatory agent.
Yes. Powerful.
Yeah.
Folks, you are picking up here on the latest developments in the area of heart disease, of how to understand it better. Remember we talked about HDL, LDL ratios? It's an interesting concept, probably held up quite well, but now we have more information. Now we begin to look at the ability of HDL molecules to be protective for heart disease. A very, very important development that we need to be aware of, even though many times your personal physicians may not understand this and may be concerned when your HDL drops in our CHIP program or in your program there, right? But you have now shown in over 20 years that these 24 people that you enrolled, that most of them, as it followed through with the program quite nicely and with an astounding adherence rate and it's an astounding compliance following through in this program, you have shown in over a 20-year study, I mean it's right in your book here, Prevent and Reverse Heart Disease. You have shown that you always use the words as, you said, heart disease, artery disease is...
Toothless paper tiger?
A toothless paper tiger,
that need never exist, and if it does exist, it need never ever progress. It's a foodborne illness.
A foodborne... It's diet-related, yeah. But if that is the case, then what are we doing in cardiology? We're not treating the disease, we're just treating...
Well, that was kind of the point of an editorial that I wrote about 4.5 months ago for the American Journal of Cardiology. And it was not to at all relate to denigrate many cardiologists who are wonderful people and great friends. But it was to point out the fact that two things have happened in cardiology. One, we use a great number of different powerful drugs to try to treat the symptoms of the disease. And we use some very, very powerful procedures, stents and bypass, which have serious side effects, morbidity, and sadly mortality.
And pretty expensive.
But the problem is that my whole thesis in this is that we're spending enormous amounts of money at tremendous amounts of sickness and associated morbidity and mortality. And Hans, it's not even treating the causation of the disease. And we really have really since the days of Hippocrates, between the caregiver and the patient, there's a covenant of trust that we are going to inform the patient of what is the causation of the illness. And I think sadly my colleagues here have abandoned that because they have felt that it was futile, that patients, if you inform them of this, that they wouldn't follow it. And is it that the advice was bad, or is it how the advice was given? One of my surgical mentors used to always say, inappropriate application of the method is no excuse for its abandonment. So we have sort of tried to re-examine that whole thesis, and we find that when we respect the patient and are willing to give them the time, in my situation it happens to be where you often get patients from out of state, they can't stay in Cleveland for days at a time, so we kind of developed this very sort of intensive counseling seminar that is for 5 hours. And
it's per person, per couple?
No, actually, now we've expanded it. We can do 10 patients at a time with their spouse, and maybe 20, but that's about the limit. But it's actually very synergistic because as the day goes on, one couple will ask a question that another couple will say, sweetheart, that applies to us as well. And yet, what you're giving them is not really rocket science, but you're taking this medical jargon and you're synthesizing it into terminology that everybody can grasp, how this disease is caused and what they can do to emerge from it. And the thing that ends up being so powerful, and I think why we have the adherence that we do of about 92%, is that they now totally understand that it is they themselves that are the most powerful locus of control for this disease.
But this is really very fascinating. You have these patients coming to you for some 20 years. You have chronicled their histories in a most admirable way. You have shown that there's a cure for a food-borne disease that oftentimes is not very well understood and transmitted to those that have entered into a covenant of trust between healthcare professional and patient, right? And we need to begin to probably not only work with our patients, but maybe also work with our colleagues to help them to understand that there are better ways than to only relying on symptomatic relief through medications and procedures. Are you with me there?
Yeah, I think, and also I think the point that I tried to make in the editorial, I think it's unfair of me to ask that a cardiologist or a physician who's treating heart disease, with the constraints on their time, maybe they don't have the passion for it, maybe they've never had really much training or they don't have the skill set for it, but they should be the ones who remain in charge of this patient's care. However, they should inform the patient of this option of care and be able to say to them, look, I'm going to take care of the medication aspects of your care, and if it is absolutely essential, we'll take care of the procedure part. But the lifestyle part of your care, which I feel is equally as important, perhaps more important than what I'm going to share with you, I am going to ask you to see my colleague, so-and-so. And I think that's how this eventually should play out, so that there's this idea that we are working synergistically in the spirit of cooperative endeavor to try to make this evolve and happen.
But even so, with a very complex disease, artery disease, which affects all of our major organs, hearing, sight, memory, the whole area, right? Isn't it amazing to see the dignity of simplicity? I mean, that's your verbiage that you have used over and over again. The dignity of simplicity, the simplicity of taking responsibility within an enlightened medical matrix, and where you become encouraged as a patient. You can do it. We will give you hope, and it will happen within 10, 20 days. I mean, that's what you have shown, right? You begin to feel better. The angina begins to leave you.
Blood pressure goes down.
Blood pressure goes down.
Blood glucose goes down.
Diabetes begins to improve. Depression begins to lift. A powerful, a dignified simplicity is coming to us. You know, we're very excited that Dr. Esselstyn can be with us. He just spoke to some 1,000 people at the Loma Linda University. He spoke to some 250, 300 physicians there at the annual medical meeting here. And also, you will see Dr. Esselstyn and our friend, really, Dr. Colin Campbell, in a Hollywood-released film that is coming out this coming May entitled Forks Over Knives. Forks Over Knives. That's the dietary fork over the surgical knife, which really means diet trumps surgery, especially when it comes to some of these chronic diseases. Look for the film, Forks Over Knives, and we want you to become encouraged and affirmed as you're reaching out to our dear CHIP people, our graduates, our alumni, and as you bring new people in, we need to reach out to people that are looking for these kind of answers. And I think the science is emerging every day more and more that we're on the right track, isn't it?
You got it.
We're looking for a major revolution. What do you call this?
I think we're on the cusp of really what could be a seismic revolution.
A seismic, now that's an earthquake type revolution.
Go. Sure, why not? Go for it.
It's good to have you with us. We had a great time in New Zealand, right. In Australia. Your wife was just spectacular in helping in a practical sense to do this kind of a thing. Easy to do, really. Once you see it, we can do it.
All right.
Thank you so much.
Bye.